know, will whole exon genome sequencing be better than polygenic risk score in his case? Talk, I thank Dr. Kamal Bhai for making me part of this interesting today's program. Kamal Bhai, yes, please. This is the book which is interacting in by us. It's for a clinician because genetics data is so complex, you always feel it's wrong. So it's only for the clinician. What is the relevance? Good morning, everyone. Can I have the first slide? I would like to share what important news, Government of India, what we thought for the 100 crores. Just 3 days before, they have just started with the project spending 8,100 crores to map 1 million genome in Indian population to have our own reference data. So that is going to take all hospitals across the country to join this, and we will from Gujarat and representing, so we'll come back also to you. Now, back to the clinical details. The 20-year-old male without symptoms mandated health checkup. His lipid level here is striking at more comfortable. His lipid is high, LDL is 192. Triglycerides is 322, LDL is normal or near low side. ECG, echo, TMT normal with CAD calcium score is 0. Pulse is normal, BP is normal. But the history, look here. History, father had CABG at 50 years of age, and mother had the angioplasty at 55 years of age. Elder brother died of sudden cardiac death at 38 years. And now we listen to the news also that this person just died while jogging. Many doctors are giving the lectures and they just die. What is the reason? Is there the health problem? Is the genetic problem? Is the overexertion? Is the stress? So this is what I think we understand from this. Next slide, please. So how do we understand now the next one? Oh, sorry. Okay. So now there is a jargon of tests available in genomics. So many companies have come. And they may just come to you as a medical representative or maybe representative, sir, you do the polygenic score, sir, you do the nucleogenomic score, you do the whole genome sequencing, or you do this panel. So you, as a clinician, you always confirm because this has not become the mainstream part of the genetics yet in many of the branch. So polygenic score, what is it? It is a relative risk indicator that comparing person's genetic profile to other people. You can see that to others in the population. It doesn't recover individual. So other populations score also included. So that estimates an individual risk of developing. Go ahead. Yeah. It estimates the risk of developing a disease by considering the effect of many genetics, not one, many genetic variants across its genomes. You can see this. So, but does not consider the environmental factors. So, large historic involves the large-scale genetic study that compared the DNA of many people with and without a particular thousands of genetic variants associated with the disease. So when we decide now, what now would be what the whole genome? So it's just association. Polygenic risk is just association. It doesn't guide us what to do. It just gives confusion. It gives so many risk links. Whole genome is a causative, is a sequence of all the protein coding sequence in the person's DNA that particularly target specific the part of the DNA and that identifies the disease that are monitoring origin, that is single gene disorders efficiently. Now, with respect to this case, next one please. What's the whole genome? Our gene has a structure like there are many exons are there. We have almost 21,000 genes. We have 3 billion letters written in ATGC. Single letter change can make us susceptible for the disease. Majority of them are this polymorphic, but many of them are anti-cis-coding. So it's more useful in present case study due to strong families, because father had a problem, mother had a problem, young mother died. So at least 2 generations of cardiovascular disease. So it will find the variants in the different gene associated with the cardiovascular disease. So mutations which change in the letters, that could be either in one or more genes related to either lipid metabolism, maybe cardiac muscle proteins, or ion channels, which could individually or collectively increase the risk of CVD. So what to now target? So genetic testing can identify inherited conditions like inherited arthropathies, like in Marfan syndrome, inherited arrhythmia, or even congenital heart disease. Go back now. So now we have this almost about more than 100 genes are involved, particularly for the normal cardiac functions. It may be involved with cardiomyopathies, with dyslipidemia, maybe hypertension, arrhythmias, congenital heart disease, and aortopathy. See? Yeah. No. Partial function? Yeah. This one? Yes. These guys. No, keep this one. What the change? Yeah. So now as a cardiologist, people may ask, do we have to do the gene panel study with cardiac, maybe for cardiomyopathies, or maybe dyslipidemia. But now, with the technology advancement, we do not require to do the gene panel. We do not require to do polygenic score. Just go for whole exome sequencing. Whole exome sequencing can give you all the answers. And now with development with AI is such a way you can look at the CNV. CNV is the copy number variation is largely similar. You can identify. Next. So government of the variance is one of boundaries can allow the clinician to tailor a specific medication regime. So different drugs are specific for management of CVD. In case of individuals where mutations are only found in the error gene or PCSK9 gene, the treatment would include the drug focused on reducing the serum LDL levels, stating or to dilute the PCSK9 gene. For dilated cardiomyopathy arising due to mutation in NMNA gene, genetic testing enables clinician to decide the course of medication or implantation of defibrillator. So this is how the genetic information will be able to help. Not only that also helps the okay, and then how it also helps the identify the mutation in the pharmacokinetics, which drug to be given, how it's going to be helpful. I know that we have been doing the certain test for the pharmacokinetics, and that in Indian population, the totally different scenario. Right now, we use all Western population, so that information is going to be helpful. And last one, in terms of the diet, if you look at this, the large study, the Copenhagen study has been done, which found that low and very low adherence to dietary guidelines that increase the risk of atherogenic lipids, lipid abnormalities, inflammatory profile, and cardiovascular disease. So it is important that the dietary, but no doubt it has not come in practice, the nutritional and the genetic interactions, but there are some studies still going on with epigenetic changes, how your lifestyles, how the genetic factors, how your dietary can help to improve the cardiac functions. And further changes in lifestyle like lipid smoking, alcohol consumption can be advised according to the results of genetic study. So systematic meta-analysis of studies have shown that alcohol consumption and ADH1C variant are the most examined risk factor for predisposition to CVD due to lifestyle choices. So thank you very much. I think now it's open because this was the debate there. So,
thank you, Dr. Jayesh, for directing us.
And a few questions.
Dr. Jayesh, to be seated, and next is Dr. Kamal.
So, respected chair, I wanted to talk about something that's going to change the way you practice. A lot of slides in a lot of conferences mentioned that there'll be only two kind of doctors left. One who know AI, one who don't. And AI will not replace doctors, but doctors who know AI will be replaced by those who don't, will be replacing those who don't. So what it's doing right now, that patient who present with convergent high risk factor, this case has an LDL of 192, TG 332, father had a bypass. There is an age paradox. He probably has premature family history of CAD. We all have these wearables. Half of us wear these smartwatches, they are smart rings, they are wearable ECG, smart clothes, smart eyewear. Everything is evolving. We know, but we don't know what to do with it. The machine is learning, humans are not. The clinical AI risk detection, which is the question that I was supposed to answer, there have been models that have looked into. There are two kinds of registries that have looked. Find FH registry and FH early registry that automatically the AI looks into. You don't have to do anything. You ask the AI to register, look at the data sets of UK, and it will tell you who is likely familial hypercholesterolemia. You don't even need a assessment by a cardiologist or a lipidologist. It will predict it with more than 85% precision. AI with lipid models, family history, genetics can actually bring and flag that this is a high risk individual, keep him asking him to come more often for evaluation. Unfortunately, NHS, they don't even evaluate an emergency case. That's a different story. But if you can pick it in this our country scenario, then everywhere, as Rajendra was saying, one phone call away, you can actually pick up whose phone call you receive and whose you don't. Polygenic risk score can also be integrated with AI. It can aggregate your genetic loci, which Dr. Jayesh was mentioning, your inflammatory markers, your thrombotic risk factor, your lipid profile, your age and blood pressure values. And with this AI tool, you will accentuate your risk prediction models by another 5 to 10% over currently available Framingham risk score. The machine learning models are predicting with gradient boosting a deep neural network to incorporate these all parameters into one. And the same story that I always say, we all have become Arjuna who just look at the eye of the fish. That has to stop. You have to become holistic. That's what AI is doing. Deep learning algorithms which have been trained in UK Biobank. Risk profile of this patient would be more than 90 percentile for 10-year risk ASCVD. Remember, ASCVD cannot be applied for anybody who's younger than 40 years age, but you can use AI to do that. So this case, if you want to phenotypically classify via the AI, it will look into the Dutch lipid clinical network and genetic algorithms, look at its clinical application. It will tell that you need a genetic confirmation, and it will pick up AI-assisted red flag and telling you that this patient would require what lipid therapy at what dose. It will also preemptively tell you when he should consult a cardiologist. The second question was, how is AI helping in devising individual lifestyle intervention? This is a slide from my patient's discharge summary. Dr. Manvi, I don't know if she's here or not. She's a diploma cardiologist working with us at Sal Hospital. She's been told that she has to give us individualized diet, not a common diet for every patient. So what we do, we use a couple of AI tools. We put the patient's clinical history. A Muslim male 50-year-old presenting with acute myocardial shock will have a different diet chart and rehab chart compared to a 25-year-old Jain monk presenting to you with an acute MI with unstable angina without cardiac shock. And this is how it looks like. It gives you diet plan, physical activity, lifestyle monitoring, exercise goal, activity description, what you should do, what to monitor, what are the red flags. You're wearing an Apple Watch, watch your heart rate, look at what is happening to your respiratory variation, keep your heart rate in what range. AI will guide your individualized intervention therapy, and this is a real life example that I picked up hiding the history. If you were to prompt it, my patient is allergic to oats, it will give you another diet plan. And then what I tell my patients is, the columns na tamara multiply kari lo 3 and 7, 21. Interchange whichever way you want to. You have that flexibility. You're not to be driven like Monday, to aaj karish. But you can always do that. So precision diet, precision lifestyle change, and then you have precision digital coaching. There are apps, we all know a lot of them, and there are a lot of people here who are experts in that. We'll have that for discussion. There are diet and AI coaching platforms like Noom, Vida, It uses what actually you are eating. All you have to do is take a picture. Right now, AI is not so smart. कि तुम्हारा मोड़ा में खाली मुंह में खबर पड़ी जाए. Right now, you have to take a picture. This is what I'm eating. It will tell you what nutritional value it has, how much calories you are taking, what is the glycemic index of this food, how much calorie you've already finished. For this food, what amount of exercise you need to do. If you've taken extra sugar, you have to walk these many extra steps, etc. It will give you real-time nudges. It will tell you your current LDL raising food consumption pattern predicts that your LDL will rise by 15 in the next 3 months. So that means the patient knows that I need to cut down on my food and I need to exercise more. It will also identify what you should avoid just from the pictures. In FH trial, I start FH trial, AI-supported nutritional platforms were able to reduce LDL beyond the common care that 2 patients were receiving. One patient, same dose statin, no AI tool. It's AI tool and same dose statin, you reduce more when the AI intervenes. So the time biometrics, digital analogs, cereal, what you can eat, this kind of new platform, if you take a picture, that's what it does. And the AI-enabled platform will do it better. Wearable technology and predictive modeling is next thing. It's going to tell you what amount of footsteps, physical activity, heart rate variability, sleep, quality, heart rate, calorie expenses that you've achieved. So if your data shows that you're not doing good in gym, next time it will not tell you, okay, do gym. It will tell you, it sees that you are actually swimming more. It will tell you, okay, swim 20 minutes more today. So it's not like your wife or your father who's pinching you or pushing you to exercise karna. It will just tell you to do more what you are actually enjoying. And this is where it is coming. It's going to go from chronic disease management, early intervention, predicting even suicide attempts. Algorithms that tell that you have a tendency of suicidal thoughts. Actually, there was a controversy that some of the AI prompts, which were not medical AI, were actually pushing patients to suicidal tendencies. But medical ones, they don't. It enhances your cybersecurity, your data gets locked, and it predicts your patient preferences as well. So when you incorporate this, all AI-driven statin response can also be predicted by the genetic variants that you have. It will do what dual therapy to give, what PCSK9 to give or not. AI will calculate your LDL goal attainments. It will gamify. It will, if you are doing something, you'll get $1 or $2 for your set goals. Extra from the app itself. App will tell you exercise more, I'll give you money. Of course, they take money first because of the subscription. Then social competition, less effective if you're an introvert, you don't have to go by interacting with humans, you can interact only with the machine. So the future is here. It's going to be bioinformatics, precision medicine, drug discovery is going to come down from 10 years to 1 year. Every year you'll have 1 or 2 new drugs rolling in next 5 years, which alter the way you treat every disease. Image analysis is already there. You have AI-based echo machines. All you need is a technician to put the probe on chest. It will measure EF, GLS, valvular regurgitation, diastolic function, ejection fraction. You do an IVUS run, it will tell you which size, length, diameter, stenosis, pre-dilatation, how much calcium, break it, how to break it, IVL, etc. And it will also give what is going to be the outcome of that procedure. In near term, in 1 to 3 years, the subclinical atherosclerosis detection is going to come by CT-FFR. You do it all doing CT angios. Now it will give you FFR severity of that lesion based on CT algorithmic derivation. 95% sensitivity, so diagnostic angiograms are going to be out in 5 years. Predictive analytics of event rates, it will also give you a digital twin. You log in, you have a digital Kamal Sharma insight for myself, and I can click on it and it will tell you, your Kamal Sharma, you are doing this is what is expected in your brain, this is what is expected in your abdomen. There will be a biobank from cardiac MR images, anatomical models, which can predict your holistic EP as well as anatomical consideration. 3 to 7 years, as I said, you'll have echo, CT, MR, coronary angio, IVUS PET, all integrated with targets of AI precision therapeutics with digital phenotyping of sensors which are going to monitor all your markers like lipids, glucose, inflammatory marker just by patch, and you can intervene at early clinical scenario. In 5 to 15 years, there is a study already doing which is expected to finish by birth, which is PTCA gene editing. So gene therapy will come in and you will not probably need any drug to treat it. You will have population level of interventions, which mean you modulate family trees and you bring down family sudden deaths by 40 to 60% within next 10 to 15 years. It's already there. You don't have to document. You have imaging platforms like Zebra, Google Health AI, Analyze AI, which are reducing reporting time. It's there very much in X-ray, CT, MR. Cardiology is next. ECG interpretations are getting more accurate. 93% of the times, it's up to date in AI already. Risk scores are going to be AI modulated. And in the next 5 years, generative AI, ambient workflow, patient-facing AI agents, integration into health record generation, and regulatory regulations will have to catch in on the same. Thank you very much.
Please be seated.